Hi, I'm Mary Ellen Copeland, and I want to welcome you to the webinar Changing Course, New Directions in Mental Health and Recovery. We've got with us tonight Robert Whitaker, who's the author of Anatomy of an Epidemic. I'm going to be speaking for a few minutes at the beginning of this webinar and again for a few minutes at the end. The last 15 minutes will be reserved for questions, and you can type in the questions during the webinar. If we don't have time to answer your questions on the webinar, please email us your questions and we will respond by email. This webinar is co-sponsored by RAP and Recovery Books. That's the organization that develops and distributes recovery information and resources based on the studies that I've been doing for the last 25 years. And the Copeland Center for Wellness and Recovery. The Copeland Center provides training, like RAP group facilitator training and the upcoming RAP and trauma trainings that are based on my studies of how people who have mental health difficulties get well and stay well. So you may be asking why we're doing this webinar with Robert Whitaker. When I first began my studies of how people with mental health issues cope on a day-to-day basis, in those days when we were not allowed to use the word recovery, I soon discovered that there were 5 consistent key concepts that people needed to use to guide their journey to wellness. Over time, as I continued to study how people cope, I discovered that there were many, many people who had in fact recovered and gone on with their lives. It was only then that I could begin to use the word recovery without being chastised for it. At the beginning, I was often told that there was no such thing as recovery in mental health, and I was accused of giving people false hope. So now we know that recovery is possible, and it's even probable, and that these key concepts support the recovery journey: hope, personal responsibility, education, self-advocacy, and support. And tonight's webinar is focusing on the 3rd key concept, which is education. Why are we doing that? Because I have found that for people to get well and stay well, they need to educate themselves. And if they can't do it, then they need to have supporters they trust who can do this for them until they can do it for themselves. Educating yourself allows you to make good decisions about all aspects of your care and your treatment. Decisions that feel right to you, that resonate with you, that support your wellness journey. And no matter how you feel about the source of your mental health difficulties, if you subscribe to the broken brain theory, if you think your mental health issues are the result of trauma, or if you're not sure of any of that, as a significant part of the education process, you need to read Anatomy of an Epidemic. And the other reason we are sponsoring this webinar is because I firmly believe, I know for myself, and I've heard from others, that RAP is the answer to the dilemma posed in Anatomy of an Epidemic. So now I am going to turn the presentation over to Bob Whitaker, who's the author of Anatomy of an Epidemic.
It's really a pleasure being here. Thank you for having me.
Well, this is great.
What I think we'll hopefully do in the next half hour is sort of do a real quick review of some of the information in Anatomy of an Epidemic. As much as possible, we'll raise some questions and all.
Yeah.
I thought the introduction was really interesting in that when Mary was first doing her work, you weren't even allowed to use the word recovery.
Right.
And now we are hearing so much about recovery, and this is sort of the new word we hear all the time, that the system should be promoting recovery. But the question we still need to ask ourselves is, the system of care we have today, the mainstream system of care we have, does it promote recovery? And that's really the question. Does it really promote robust recovery where we help people get back jobs, get back full social lives, have good physical health, or not? And that's really what I was trying to look at in Anatomy of an Epidemic, that big picture. And if the current sort of medication-based paradigm of care isn't doing that, then the question is, does science show us that maybe we need to embrace a new paradigm of care, one that really promotes robust recovery? Because I agree with you. I think if we look in what history and science are telling us, is that recovery is not only possible but can be expected, provided you provide the right context for that to happen. So that's what we're going to look at. So the first question that I looked at is, how are we doing in the United States? Are we promoting recovery? And one of the ways I sought to do that was just look at the number of people on disability in the United States receiving SSI or SSDI due to mental illness. So you were doing that initial work in the 1980s, right?
Yep, late 1980s.
1980s. Now, in 1987, we got Prozac arrives on the market. This is, the first of the second generation SSRIs. These new antidepressants are supposed to be better than the old antidepressants. And then a few years later, we get the atypical antipsychotics, Zyprexa, Risperdal. They're supposed to be better than the old drugs. And we have this, at least in theory, new medications to help promote recovery, right? And so I just looked at the number of people in 1987, when Prozac arrives, on disability due to mental illness, age 18 to 66. And in that year, there were 1.25 million people. We spent $800 million on psychiatric drugs that year. 20 years later, we were spending 800 million, right? 20 years later, we were spending $40 billion. So we really embraced the use of these medications.
Huge.
So what happened to disability numbers during that time? We would hope that they would stabilize, right? Because we would promote this robust recovery.
Right.
Instead, they went from 1.25 million to 4 million people. They more than tripled. So right there, we see a dilemma and sort of a paradox. We're talking about recovery. We're talking about how we're getting ever better at it. And yet what we see are rising disability rates. So you see a question, is there something fundamentally wrong with this medication-based paradigm of care? Now, one of the things that has happened since I wrote Anatomy of an Epidemic is I've been asked to speak in other countries. So as I've gone around to speak at other countries, I've looked at what's happening to disability rates in other countries that have embraced this paradigm of care. And what you find in country after country, where we've really adopted the medical model, made medication the centerpiece of care, you're seeing the same rise in country after country. In New Zealand, a fourfold rise in disability from 1991 to 2010, from about 12,000 adults to 50,000 adults. How about Australia? Well, they went from around 50,000 people on disability in 1990 to about 225,000 in 2010. A fourfold increase.
We're supposed to be getting people better, but we're getting a lot of people.
Well, this is the question, right?
Yeah.
Why do we see this rise in disability numbers in country after country? How about Iceland?
Yeah.
Now, the chart you have here is just looking at the number of people going on disability per 100,000 population. And you see in the early 1990s, it was going around at about 150 people per 100,000, 75 women, 75 men. And what's really interesting about this graphic is it's in the mid-1990s, 1995, 1996, 1997, that Iceland really embraces the use of the new drugs. And now watch what happens. We went from 150 people per 100,000 in 1998, 1999, and now we're at about, so we went from 150, and now we're at about 400 per year. So you see in country after country this rise in disability, which doesn't tell you anything about the merits of the medications, but it does raise a question. Is why? Is it associated? And if you look at the disability numbers, by the way, it's really affective disorders, more depression, more bipolar cases, et cetera, that are driving the disability numbers. So I think we can all agree that if we look at these numbers, we need to do something different. We can't just have the disability numbers rise, and what we really want is a system of care that gets people back to work and all. So something's going on here that isn't promoting it. Okay, so the next thing I wanted to look at in Anatomy of an Epidemic was a key part of this whole medical model story, and the story of progress. So if we look at the story that drives our paradigm of care today, it goes like this. We get Thorazine and arrives in asylum medicine in 1955. This kicks off this psychopharmacological revolution, this great leap forward, right? And that's the first antipsychotic. And listen to the name, antipsychotic, as if the drug is fixing something specific to psychosis. It's an antidote to psychosis. We get antidepressants. We get anti-anxiety agents. So there's a sense they're specific agents. And then what we hear in the 1980s and 1990s is that these drugs fix chemical imbalances in the brain, and they're like insulin for diabetes. Now, if that's true, that is a story of great medical progress, because if you look at some of the great advances in medicine, you identify the pathology, and then you get a drug or a therapy that's an antidote to that pathology. And that's what we've been told has happened in psychiatry. We've identified the causes, chemical imbalances, and then we have drugs that fix that imbalance. And by the way, there was a survey not long ago of the American population, and 87% of Americans now, quote, know that schizophrenia and other psychotic disorders are due to too much dopamine in the brain. And 80% of Americans now know that depression is due to low serotonin.
Yeah.
So as we try to investigate this paradigm of care we have, we want to see, is this true? Okay. Now, when you investigate the chemical imbalance theory of mental disorders, what you find very quickly is it didn't arise from an understanding of what was going on in the brains of people so diagnosed. It arose from an understanding of how the drugs acted on the brain. Okay, and it really goes back to the 1960s and 1970s. So, for example, let me go back. So, what they learned was that, say, antipsychotics block dopamine receptors in the brain. So they thwart dopaminergic transmission. They reduce it. They act as a brake. So what they hypothesize, well, maybe people with schizophrenia have dopamine hyperactivity, overactivity, the opposite. They figure the drug acts as a brake, well, then maybe the problem is too much. But you see what's happening here. The hypothesis to fit the drug action as opposed to the opposite. If we go to the low serotonin theory of depression, and we can jump forward on that, we see it arises from an understanding basically of how, let's say, the SSRIs act on the brain. What do the SSRIs do? They up serotonergic activity. So we hypothesize depression is due to low serotonin. Well, I'm not going to go into depth in terms of how they investigated this, but if you see this slide that's before you right now, the low serotonin theory began to be investigated in the 1970s and early 1980s. And now they looked, do people with depression, do they have low serotonergic activity? Do their presynaptic neurons put out too little serotonin? Or do their receptors for serotonin on their postsynaptic neurons, are there too few of them? And guess what they found by 1984? By 1984, the NIMH was reporting that, read this, elevations or decrements in the functioning serotonergic systems per se are not likely to be associated with depression. So once they looked in people who had actually had depression, they didn't find that they had low serotonin. Now this, and you can see sort of the problem right here, right? And then what our understanding is known is out of sync with the science. Here's another quote by Stephen Stahl. Now, Stephen Stahl is a famous molecular psychopharmacologist. He believes in biological psychiatry. He writes a textbook called Essential Psychopharmacology in the year 2000. And he says this about this low serotonin theory of depression. There is no clear and convincing evidence that monoamine deficiency, serotonin is a monoamine, accounts for depression. That is, there is no real monoamine deficit. So they looked and did not find it to be so. Now, basically the same thing research was done for schizophrenia. Do people, prior to being medicated, do they have overactive dopamine systems as a matter of course? They did not find that to be so. There may be some subsets of population where there's sort of spikes in dopamine activity, but is there a real malfunctioning of the dopaminergic systems? Found it not to be so. Now, the quote before you on the slide is by Stephen Hyman. He's a neuroscientist at Harvard. He's a former director of the NIMH, and in his book, Molecular Psychiatry, he says, there is no compelling evidence that a lesion in the dopamine system is a primary cause of schizophrenia. So that simple theory fell by the wayside. Then in 2005, Kenneth Kendler, who's co-editor-in-chief of Psychological Medicine, wrote a paper in which he summarized this long search for chemical imbalances in mental disorders. And here's what he said. He summarized how it arose, because in understanding how the drugs acted on the brain, how it was investigated, and he concluded, we have hunted for big, simple neurochemical explanations for psychiatric disorders, and we have not found them. So where are we at? You can see the sort of problem our society has. People go to their doctor, and let's say they're depressed, or maybe they have, quote, psychotic symptoms, and they're told, you have a chemical imbalance. The drugs are like insulin for diabetes. You have to take this drug for life. So what's wrong with that? That's what you were told, right, Mariel?
I have to take this for the rest of your life.
Okay, so let's go through what's wrong with that. Is it right to tell someone that they have a known biological problem when that's not what the evidence showed? No, I'm asking, is that right? Is that an honest way to treat patients?
No.
You don't do that, right?
No.
We wouldn't tell someone that you have a hole in your heart if you didn't have a hole in your heart.
No.
So we're in this arena of medicine where basically people go told they have a chronic disorder, that they have a brain malfunction, and the research did not show that. So that's our first problem.
I was told it would probably get worse as I got older.
So the second problem is you rob them of hope, right? I think that was your top thing on your wrap, wasn't it? Hope.
Right, yeah.
So we take hope right away.
Yeah, right. We just get rid of that.
Which is quite an amazing thing for medicine to do.
Right.
But it's not only this, it's a false robbing of hope. Because in fact, we didn't find what was wrong. Now, maybe there's some biological substrates, but we don't know. That's the first problem. The second problem is it's hard to make artful use of medicines. And think about this. The rationale for forever use is that they're like insulin for diabetes. They're fixing an imbalance.
Yeah, yeah.
Well, if that rationale disappears, maybe the rationale for long-term use disappears as well. So it's very hard to have artful, thoughtful use of medicines if you're deluded about what they do.
Right.
And what this research shows is this. Our society has been told one story, and science tells another. Yeah. So the first thing we need in the new paradigm of care is honest storytelling. And the honest storytelling is we don't know what's biologically wrong, which obviously opens up the possibility that, hey, you can really have robust recovery. This could be episodic. Who knows what happened, okay? So that's, I think, an important thing to realize. The chemical imbalance story is a falsehood, and it is unnecessarily pessimistic. And it tells of broken brains when we didn't find them. Now, then we do then have to ask, well, what does happen to the brain when you go on a psychiatric medication? So, and this is the slide you see in front of you is from a paper written by Stephen Hyman. Mm-hmm. When he wrote this paper, he was director of the National Institute of Mental Health, so this is mainstream sort of understanding of psychiatric drugs. What he says is these drugs create perturbations in neurotransmitter functions. What does he mean? Think of an antipsychotic. The antipsychotic blocks dopamine receptors in the brain. Mm-hmm. It's perturbing it. It's blocking it. Mm-hmm. Okay, that's what he means by that. Now, he says in response to this, the brain goes through compensatory adaptations in order to, quote, maintain their equilibrium in the face of alterations in the environment or change in the internal milieu. What does he mean by this? The drug, say as an antipsychotic, is acting as a brake on dopaminergic transmission. Your brain has all these feedback loops and it says, aha, I need to put down the accelerator to try to maintain my normal function. Mm-hmm. And how does it put down the accelerator? Well, if you go on an antipsychotic, your presynaptic neurons, the neuron that releases this chemical into the synaptic cleft, will put out more dopamine than normal for a while. Now, then that compensatory adaptation breaks down. Yep. And then the receiving neuron, which we call the postsynaptic neuron that receives the messenger, the dopamine, will actually increase the density of its receptors for that molecule. Mm-hmm. And the reason is it's trying to become extra sensitive to dopamine to make more use of the dopamine that's out there. It's trying to compensate for the presence of the drug. Then what does Stephen Hyman say? He says the chronic administration of the drugs then cause substantial and long-lasting alterations in neural function. Mm-hmm. In other words, you're changing the brain, right, in this way. And he says after a few weeks, the person's brain is now functioning in a manner that is both, quote, qualitatively as well as quantitatively different from the normal state. So what does science tell us? Science tells us that we don't know anything that's abnormal. You don't have a chemical imbalance before you go on the meds. But the meds do, they turn the brain in a way that it operates in an abnormal fashion. So in essence, I think we can say these are abnormalizing agents. They're not normalizing agents.
Abnormalities in the brain.
Right. Now, we don't know. That doesn't tell us whether the medications are going to be helpful or not long term. We have to look at the research. Mm-hmm. But once you have this conception of the drugs, I think a couple things happen. A, you can see why going on the drugs in the first place is a profound thing, right? You're going to change your brain. That's number one. Two, I think if you can understand that these are abnormalizing agents, why you might get a lot of side effects, right?
Yes, because they're absolutely.
Third, you can see why maybe long-term use can be problematic. Mm-hmm. And the fourth thing is this. Let's go back to the antipsychotics. Mm-hmm. They act as a brake. Mm-hmm. Your brain puts down the accelerator. Yep. Now take away the brake. What do you got down? The accelerator, right?
Yeah. Yeah.
So now you can see, once you understand that, why once you go on, why coming off can be so hazardous. Okay. Right. So a lot of things start to make sense.
Right.
Okay, now I'm going to skip through this just a bit. But one of the things I then tried to do in Anatomy of an Epidemic is look at this question. How do psychiatric medications shape long-term outcomes?
Right.
And that's a very different question than what the FDA is looking at. What the FDA looks at is to approve a drug is, do they knock down the target symptom of disorder better than placebo over the short term? Okay. And psychiatric drugs more or less do that. But I want to know this. Imagine we had two groups of people come into an emergency room. One group is treated with meds. The other group is treated with psychosocial care and no meds. We followed them for 15 years.
Yep, that'd be great to do.
And that's the question I'm sort of trying to ask is, are we improving on the natural course of the disorder? That's really the big question. And because of time, real quickly here, just so we know where the evidence base does come from the use of psychiatric drugs. We have short-term studies, and then the second part of the evidence base is this. Once you have people on antipsychotics, and hopefully some people are stabilized, they ran studies where half the people were abruptly withdrawn, the other half were maintained, and with great regularity, those withdrawn from the drug relapsed at a higher rate. They had return of symptoms. But is that due to the withdrawal of the drug?
Right.
Because usually these are abrupt withdrawal. We don't know. I mean, obviously it could be due to the withdrawal of the drug, or at least partly. The other thing is, do those relapse studies tell us anything about how well people are functioning over the long term?
Right.
Does it tell about employment? Does it tell about socialization? Does it tell about cognitive function? So the evidence base for long-term use is simply this. Once you go on the medications, say antipsychotics, coming off is perilous. But it doesn't tell us how well people are functioning, okay? So what we're now going to look at is a very different question in the next 15, 20 minutes. Is how do medications shape long-term outcomes? And we're going to, in an anatomy of an epidemic, I do that for schizophrenia, I do it for benzodiazepines and anxiety, I do it for antidepressants and depression, and I do it for bipolar. Obviously, we don't have time to do all four tonight. So what I thought I would do is sort of rush through the literature for antipsychotics and schizophrenia. Now, one reason for this is if any class of drugs should have a clear benefit, it's antipsychotics. Because what's the standard of care? You put people on right away, right? And you keep them on. In fact, it's considered basically against standard of care to withdraw. So let's see what the literature shows us. So real quickly, you see a slide in front of you right now. The first thing I did as a journalist, as I went through the literature, and I looked to see if there were other researchers that can say, okay, yes, those relapse studies don't tell us anything, but is there other literature that tells us antipsychotics are improving long-term outcomes for schizophrenia? And what you find when you do that is something amazing. They say, we don't have that evidence. Emmanuel Stipp, he's a well-known psychiatrist, a Canadian psychiatrist. He wrote a paper in 2002 by European Psychiatry, and here's what he said. After 50 years of neuroleptics, and that's another word for antipsychotics, are we able to answer the following simple question? Are neuroleptics effective in treating schizophrenia? And he says, there is no compelling evidence on the matter when long-term is considered. And then he says this. For me, this was like a green light as a journalist, that this is an inquiry worth pursuing. He says, if we wish to base psychiatry on evidence-based medicine, we run a genuine risk in taking a close look at what has long been considered fact. And that's what we're going to do here in the next 20 minutes. We're going to take a closer look at what has long been considered fact, which is that these drugs are absolutely essential for treating schizophrenia. Real quickly, what sort of outcomes were we getting in the United States with first episode schizophrenia prior to the arrival of Thorazine? Now, the common belief is people went into the hospital and didn't get out, right? It wasn't until you get Thorazine that made it possible to have people in the community. What you find is that's not true. If you look at outcome studies from 1945 to 1955, first episode schizophrenia, roughly 65, 75% would be discharged within 18 months. At the end of 3 to 5 years, about the same percentage would be living independently in the community. Employment rates were above 50%. So actually what you see in the literature from 1945 to 55 is a heterogeneous spectrum of outcomes with first episode schizophrenia, and it really goes like this. 5 years later, about 1/3, they're just not, quote, schizophrenic anymore. They're asymptomatic. There's another third that maybe still has symptoms, but they're able to function in the community independently. They don't need to be in the hospital. A lot of them are working, a lot of them are getting married, that sort of thing. And there's just this third that really has become chronically ill. So we see a lot of possibility, robust recovery there from that 1945 to 55. But unfortunately, we've forgotten about this. Okay. First long-term study. There was a study done in the early 1960s by the NIMH. 4 arms, 3 groups treated with a drug, 1 group with placebo. At the end of 6 weeks, the drug-treated group was doing better. But actually, many placebo patients also improved. They're discharged. And now what do the NIMH researchers report a year later? They say that at the end of 1 year, patients who were treated with placebo upon initial hospitalization, quote, were less likely to be rehospitalized than those who received any of the 3 active phenothiazines. And phenothiazine is a neuroleptic antipsychotic. So you see something odd here? The very early moment of the long-term literature, we see the hint of drugs. We see drugs that are effective over the short term. Are they increasing perhaps the chronicity over the long term? Okay, next study we have a retrospective study done by Sanborn Bachhoven at the Boston Psychiatric Hospital. He had data from a 1947 cohort, 5-year data. He compares that data to a 1967 cohort. In 47, thorazine hasn't arrived, so they're not treated with drugs. 67, they have. And what does he find? Well, one, he finds that the relapse rate is higher in the 67 cohort, more rehospitalization. And even more important, he finds is that the functional outcomes were much better in 1947. In 1947, 5 years later, 76% were successfully living in the community. That number has disappeared from our collective memory. 67, he says, they're now much more socially dependent, on welfare, needing other forms of support than the 1947 cohort. So what does this retrospective study show? It shows a decline in functional outcomes. So what did Bachhoven say? He says, rather unexpectedly, these data suggest that psychotropic drugs may not be indispensable. Their extended use in aftercare may prolong the social dependency of many discharged patients. Again, we see this paradox happening. Now, we have 2 studies done by the NIMH in the 1970s that revisit this question of antipsychotics with the longer term, in other words, over either 2 years or 3 years. The first one was done by Maurice Rappaport at the University of California, San Francisco. 80 first episode schizophrenia patients. They go to the hospital and they're randomized either to med or placebo in the hospital, and then they're discharged and they're followed for 3 years. And when they're discharged, they can either, let's say you're treated with placebo in the hospital, and actually it's not placebo, it's no med in the hospital. You can either stay off the drugs or you can go on, okay? And then if you were treated with drug in the hospital, maybe you're going to go off in the 3 years, okay? So what does he report? And by the way, those of you who are looking at the graphic, when it says no meds off, that means no meds in the hospital and off in the 3 years following, okay? Antipsychotic off means antipsychotic in the hospital and getting off once they were discharged. Well, of the 41 patients that were treated with no meds in the hospital, 24 never needed to go on antipsychotics. And it was that group, the never exposed group, that had by far the best 3-year outcomes. Okay, if you, on the severity of illness score, much, much better than any of the drug exposed groups. And the rehospitalization rate, 8%. 8%. Now, what was the rehospitalization rate for those who went on drug and stayed on drug? 73%. So the never exposed, 8%. The ones that went on drug, stayed on, 73%. Okay? And what is Rappaport's conclusion? Our findings suggest that antipsychotic medication is not the treatment of choice, at least for certain patients, if one is interested in long-term clinical improvement. Many unmedicated while in hospital patients showed greater long-term improvement, less pathology at follow-up, fewer rehospitalizations, and better overall functioning in the community than patients who were given chlorpromazine while in the hospital. So you can see he's surprised, right? He's surprised that that there's a subset of patients that can get through their psychotic episode and do quite well. And really what you start to see here is sort of a selective use model, and that there's a subset of first episode patients that would do better if not going on the meds. Now, I just want to say a caveat for the people listening on the internet. This talk is not about medical advice. Okay, no one should make any treatment decision based on what we're talking about here. What we're trying to do is present information at a society level that says there's this treatment we have right now, which emphasizes basically one size fits all, go on drug and stay on drug. Is it scientifically justified? But no one should make any decision based on this, the data they see here. The next such study we had was it's called the Psychiatric Project. It was run by Lauren Mosher. He was the head schizophrenia doctor at the time. And basically he had this sort of care. Either people were treated in the hospital conventionally with drug, or they were taken to a home, a Victorian house. And at that house, people would just be with them. And the drug use was this. They would use benzodiazepines to help quiet people right away if they needed to sleep wake. and then they tried to delay use of antipsychotics. If people got better without the antipsychotics, then they would continue not to put them on, but if not, they would put them on. So it's a selective use model. And what did Lauren Moshe report? He reported at the end of 2 years, the Soteria patients had lower psychopathology scores, fewer readmissions, and better global adjustment. Again, this selective use model produced better outcomes. In terms of antipsychotic use at the end of 2 years, 42% had never been exposed to the drugs, 39% had used them temporarily, and 19% had used them regularly throughout the 2-year follow-up. So what you see in this mid-1970s thing is really maybe a better model of care is selective use, and you figure out for whom and for how long, rather than a one-size-fits. Oh, again, what does Lauren Moshe conclude at that time? He says, contrary to popular views, minimal use of antipsychotic medications combined with specially designed psychosocial intervention for patients newly identified with schizophrenia spectrum disorder is not harmful, but appears to be advantageous. We think the balance of risks and benefits associated with the common practice of medicating nearly all early episodes of psychosis should be re-examined. Okay, I'm going to have to skip forward here just because of time. There was another study done in-house by the NIMH, same thing. It was the unmedicated group that actually had better outcomes. This led the NIMH to raise a question. He says there's no question that once patients are placed on antipsychotics, they're less vulnerable to relapse if maintained on them. But what if these patients have never been treated with drugs to begin with? And listen to this. He says, we raise the possibility that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. So what they're worrying here is that the drugs are causing a biological change that ironically increases the chronicity of the disorder. Yeah. Now, because of time, we're going to skip ahead, okay? We're going to skip ahead to this study right here. Actually, you know what? I can do real quickly. The answer to this, the biology, was this. The drugs, antipsychotics block dopamine, right? In response to that, researchers said you get an increase in dopamine receptors. The brain is now super sensitive to dopamine, and what the researchers said is, we think this is what is causing the increased chronicity, okay? Now, let's go to one last study, and then we'll wrap this up, okay? The best prospective long-term study we have, the only one we have is study in the literature that followed people for 15 to 20 years. And this is what we want to know, is how people fare long-term, right? We do want to know how people fare immediately, but we want to know long-term. It was done by Martin Harrow at the University of Illinois, and basically he recruited 200 patients into a study. They were recruited from 2 Chicago area hospitals, one private, one public. Everybody's treated with drugs in the hospital, okay? And then they're discharged, and he just follows them up for the next 20 years at 2, 4.5, 7.5, 10, 15, 20. He looks at, are they symptomatic? Are they working? Are they socially engaged? Are they anxious? And are they taking antipsychotic medication? Now, the theory is, of course, the purpose of the study is to find out what happens with people who go off their medication. Yeah. The theory is they're going to be doing terribly. They're going to be homeless, in jail, etc. Yeah. Okay. He ends up following 145 patients. He still has that of the original 200, 15 years later. And it breaks down into 2 groups, 64 schizophrenia patients, 81 with milder disorders, okay? And it's a young group, half its first hospitalization, okay? So we're getting people early in the course of the disorder. Here's recovery rate. By the way, to be in recovery, in his study, you had to be working half-time or more, okay? And you had to be asymptomatic. At the end of 2 years, roughly 20% of those off medication were in recovery versus about 8% of those on medication. That's at 2 years, okay? And by the way, of the 64 schizophrenia patients, roughly 25 got off, okay? If you look at this graph, you'll notice something really notable, because you don't see this anywhere else in the research literature. Look what happens between year 2 and 4.5. There's a lot of recovery in the off-medication group. The relapse studies don't show us. Nothing else shows this. The recovery rate jumps from 20% to 40% in the off-med group between the year 2 and 4.5, whereas it actually goes down a little bit for the on-medication group. So by the end of 4.5 years, the recovery rate for those off-meds is 40%. For those on-meds, it's 5%. 8-fold higher recovery rate. And you see in this slide, it stays that same throughout the study, okay? Here's the global adjustment of all patients. You'll see, again, at the end of 2 years, those off-meds and those on-meds, not much difference. The separation happens between 2 and 4.5 years. So do you see a lot of healing here? Yes, but it takes time, okay? By the way, this is healing going on where people are leaving the system. Yes. No one's getting help here. Right. These are people who are ignoring medical advice to go off. Okay, and again, I want to say, no one watching this webinar should make any decision on this. We're just trying to present some data that we think needs to be presented. Harrow also has a spectrum of outcomes. At the end of 15 years, he has recovered, so-so, uniformly poor. Look what happens here. The off-med group, 40% in recovery. This next number should actually be 44% so-so, 16% uniformly poor. How about the on-medication group, those who kept on taking their antipsychotics? 5% in recovery, 46% so-so, 49% uniformly poor.
Terrible.
So it's not just a lower recovery rate.
Yeah.
It's with the on-medication group. It's much more in the uniformly poor group. Okay. How about psychotic symptoms? Which group is more likely to be psychotic, still actively psychotic at the 10 and 15-year follow-up? At the 10-year follow-up, 79% of those on medications were still actively psychotic, had symptoms, versus 23% of those off. So you see more psychotic symptoms in the on-medication group. That's the same in the 15-year. I mean, at the 15-year follow-up. Now, Martin Harrow, if you read his paper, he says, what happened was the people who got off were more likely to have a better inner sense of self. And it was those good prognosis patients who got off. And so really what he says is, in his discussion, we just need a paradigm of care that allows this one subset to get off, okay? And because there's certainly a subset that does better off. Actually, if you look at his data, it's more complicated than that. The good prognosis patients who got off did better than the good prognosis patients who stayed on. The bad prognosis patients who got off did better than the bad prognosis who stayed on. So it's more complicated than that. Now let's look, but he does conclude this at a meeting of the 2008. He says, I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global functioning than those on antipsychotics. This is the best long-term study we have.
Today we are going
That's the best long-term study we have. And do we hear this? Is this part of our information that the public is known? This conclusion? We don't hear this, do we? Okay, how about the global adjustment of other psychotic patients? Again, it was the off-medication group. That's with milder disorders who did better long-term. Now look at this next slide, Mary. This is a slide I think that we should have on the front page of the New York Times.
Yes.
Because what happens is Harrow ends up with 4 groups. He ends up with schizophrenia off, schizophrenia on, milder disorders off, and milder disorders on. So what's the best group? Milder disorders off. They have the best outcome.
Yep, absolutely.
The second best is schizophrenia off.
Yes.
Third is milder disorders on, worst is schizophrenia on. So the question we as a society need to ask, which I think the New York Times should put on the front page, is why does schizophrenia off end up better than milder disorders on? Because at the beginning, those with milder disorders have a better prognosis.
Yes.
So why do we get this cross?
Right.
Okay, real quick. He's now got his 20-year data. It just came out, and this is a really important slide. At the end of 2 years of the schizophrenia patients, about the same percentage are experiencing high anxiety, okay? Look what happens between year 2 and 4.5. Those who go off antipsychotics show this dramatic decline in anxiety, where those who stay on actually show an increase in anxiety. Now, anxiety is associated with outcomes. This is 70% of those on medication are experiencing high anxiety, and it's like 15% for those off. And when does the healing happen? When the anxiety decreases. And what I think you're seeing here, what you may be seeing here in the medication group, is a bit of tardive akathisia. Akathisia is this inner agitation that is associated with anxiety, and tardive means maybe it's settling in a more sort of permanent state. We really need to look at this data and say, why does the off-medication group become less anxious while those on become more anxious? Just if you go forward, cognitive function better in the off-med group. And so then Martin Harrow raises this question that I think we need to ask ourselves as a society. Is very long-term treatment with antipsychotic
questions.
undesirable?
Even when I open this,
Okay, last question. Last point is this.
it doesn't
Where are we
show
seeing the
questions
best
when
outcomes
you,
today
I guess I can
in psychotic
put one
treatment
in,
the
but
Western world? It's in Western Lapland. In 1992, Western Lapland decided to revisit its use of antipsychotic drugs, and they adopted a selective use model in which they did not put people on their first episode psychotic patients on drugs right away, antipsychotics, and they tried to get them through the break without putting them on. Now, if people weren't getting better, then they put them on for a period of time, and then Then they would again look at who needed to stay on and who could go on. So what are their 5-year outcomes now, Mary? Because this tells us what's possible.
Right.
At the end of 5 years, only 20% of their first episode patients are on disability. The others are working or in school, 80%. What percentage are asymptomatic? 80%. So what we're seeing is they have turned psychosis away from a chronic condition basically into an episodic disorder for about 80% of their patients. And how about medication use? 2/3 have never been exposed to antipsychotics at the end of 5 years. 20% take them regularly, and then there's this other group that use them periodically. I want to say one last thing, and then we're going to open up for questions.
Yeah, I have a few things I want to say too.
Great.
Yeah.
This is not an anti-medication protocol.
Yes.
They use benzodiazepines right away to restore sleep-wake. What they're doing is trying to find out for whom and for how long. It's a selective use model, and what we're really seeing here is artful use of medications can lead to robust recovery.
Yeah, that's great. But I want to say that probably you're all saying, you know, I'm taking these medications, or I'm working with the people that we're all have been taking these medications for a long time. What can we do? This is really hard. What can we do? And the first thing I want to say to you is, if you are using or considering using a medication, use this form that we have on our website, Questions to Ask the Doctor About Medication, to get all the information you need to know about that medication. Questions to Ask the Doctor About Medication, you go onto our website, rapandrecoverybooks.com. On the front page, it says, on the right-hand side, it says, download forms. Download the form that says Questions to Ask the Doctor About Medication. It has questions like this. How does this medication work? What do you expect it to do? How long will it take to achieve that result? What are the risks associated with taking this medication? What kind of an effectiveness track record does this medication have? What side effects does this medication have? What tests will I need prior to taking it? What symptoms indicate that the dosage should be changed or the medication stopped? That's just a sampling. You really need to take this form to your doctor. If they can't give you the answers to those questions, you can look them up on the internet, you can look them up in the library, but be sure you know those answers. And if you can't do it for yourself, get somebody else to do it for you. And then I also want to point out RAP, that we have lots and lots and lots of reporting now. We have an evidence base that proves that RAP helps people to get well and stay well. And you probably all know RAP. It includes a wellness toolbox where you look at all of the resources you have, and then you use those to figure out what you need to do every day to keep yourself well. What are the things that might upset you, and then develop an action plan so that if things upset you, you have an action plan so that you get yourself feeling good again. Identifying your early warning signs. What are the early warning signs that you're not doing so well? And using those resources to develop an action plan of how you can get yourself feeling well again. And then that time when you are really not doing it all well. And when we started talking about this, this was actually like, and they figured out what it was that they could do. And now people are using these kinds of plans to avoid using crisis services and to get themselves well and keep themselves well. I use this plan all the time. This is how I keep myself going. I have a diagnosis that will probably be on my charts for you know, the rest of my life in all the hospitals that I don't go to anymore, because I use this. I use this, and I have had some very hard things happen in my life. I've gotten to that point when things are breaking down, and I've had to use my plans to pull myself back up so that I could keep going. And RAP also includes an advanced directive and a post-crisis plan. So this is easily accessible for everybody. So I want to just say quickly, why RAP? You can use it right away. You can use it as soon as you begin feeling crummy. You can use it yourself. The doctor should be introducing it to you. There's no need for assessments or diagnosis. There's no harmful side effects. It's evidence-based. We have huge bodies of evidence now. We have a big study in Ohio. We have a study that's ongoing now in Illinois. We're last listed on the national evidence, the national, oh wow, National Registry, thank you. Dan Fisher is here, and Dan says National Registry of Evidence-Based Practices. I need all the help I can get. Provides hope, it improves the quality of life, it can lower the healthcare costs, I've seen that. It builds self-agency, which is so important. It can be easily and safely used to address all health and life issues and needs. It integrates all treatment options and choices, whatever you want to use. It's self-determined. It focuses on strengths, and it focuses on the fact that there are no limits to recovery. My family was told that I would never get any better and that I'd probably get worse, and that they would have to figure out how they would take care of me because they don't put people like me in institutions anymore, kind of maintain them in the community. And since that time, I've done fairly well. So RAP addresses the whole person, emotional, physical, spiritual. And as I said, RAP works. It's recognized by the Federal Substance Abuse and Mental Health Service Administration and is listed by NAREP. And you can go online and you can see all of the research. All of the research is online at our website at RAP and Recovery Books, or if that's hard to remember, just go to mentalhealthrecovery.com. And we have many RAP resources that you can use to do this. So you can go to a RAP group, you can do it some fancy way, and you can do it with all the bells and whistles, where you can just pull out the book and do it yourself. RAP groups are great. People learning from each other, people who have similar issues getting together and learning how to do this is really, really great. So again, RAP and Recovery Books and the Copeland Center trains RAP group facilitators and does all other kinds of trainings, and that's the premium. That's the best way to get it. So that's what I have to say, and we're going to go on now to questions.
The first question will be for Robert. And Robert, have you presented this to groups of psychiatrists? And what is the prevalent response to what you are putting forth?
You know, actually,
we have a psychiatrist here in the
we have one right here in the room.
Yeah.
You know, it's really been actually interesting. I am increasingly being asked to present this evidence, this presentation to psychiatrists. I've done a number of grand round presentations now, different medical schools. There was a group that got me invited to the American Psychiatric Association meeting last October in San Francisco. It wasn't the main one, it was like the Institute of Community Psychiatry part. I recently presented at the Group for the Advancement of Psychiatry, which is a group that's sort of like a think tank for the APA. A lot of former heads of the APA were there. And here's the reaction. Sometimes people are unhappy, and there's a lot of tension in the room. But at the same time, what has not happened in any of these forums yet is where people have been able to say, and here's our data showing that we're improving long-term outcomes. Here's the counter story. It hasn't come forth. And so that actually tells me that you know, this is their data, but it's sort of a way to assess the validity of it, or to confirm that, yes, this is a solid evidence-based presentation. So that's the first thing. The second thing I will hear from people is sort of, well, we've always known that some people do better off medications. And then I often hear from psychiatrists go, I take my schizophrenia patients off all the time. Or I take my psychotic patients off all the time. And I use these drugs in a selective manner. And I say, that's great, but I'm not sure that's the standard of care in many places in the United States. So what you see really is sort of a defensiveness, and I understand, because this belies what they know to be true. It belies their standards of practice. But what you and here's what it is, I think that does need to be noted. They haven't seen this data put together like this before in this coherent story. So they're actually surprised to see the coherence of this data that goes all the way from the 1960s to 2012. And when they see it all together, all these pieces, you do see some, you know, what was the word? Someone was in the grand rounds in Burlington, Vermont a while back at the medical school there. And they said they could hear in the silence minds cracking open. Which I thought was a beautiful line. And actually, I think that's what I'm seeing in some of these grand rounds, and the fact that I'm being invited tells me that people have vetted this book, looked at it, and said, maybe we really should look at this, and maybe we should make some changes. So that's a long-winded answer to say, I think there's psychiatric groups that are actually trying to deal with this literature.
Okay. Here's a question that I think a lot of people would like to know the answer to. What should you do if you don't think you are capable of getting off the medication, if the circumstances have been so severe that it would be foolish to even try to reverse the dose?
Maybe we should ask the psychiatrist here. Seriously. No, I think this would be good. I'm not a doctor, so the point is I never give medical advice. And I would not like anybody to take medical advice, but we have a psychiatrist in the room with us, Dan Fisher, so maybe he can answer that, because that's really a medical advice question.
Well, thank you, Bob. This is a little bit unexpected. I enjoyed your presentation very much, and Mary Ellen. If somebody feels that their life situation is very severe and they're concerned, they should continue, though, to develop a good working alliance with their doctor, and they should continue to work on things like Lapland and psychosocial aspects. They should come to know themselves, and gradually over time, I have every confidence that just about everybody could either greatly reduce or come off of their antipsychotic medication. But it should be done very gradually, and it should be done in conjunction with a doctor. And the challenge today is to retrain doctors and the rest of the psychiatric and clinical staff to understand that once you form a good relationship, you can have much more flexibility. The art, I feel very much, of finding the right amount and finding who doesn't need and who maybe only needs a very little bit of medication is the relationship. Absolutely essential. So people need to have time with their doctor, and they need to trust their doctor, and their doctors need to have faith and confidence and hope that they can get better.
Great. Thanks, Dan. Thanks so much. Thanks. Thanks.
There's a simple question. What is open dialogue?
You want to do it? So open dialogue is the form of care that was pioneered in Western Lapland, which is a district in northern Finland in 1992. It has a very different conception. Right away, they don't conceive of psychosis residing in the brain of the person, the designated patient, but they say psychosis resides in the in-between spaces of people, and the person who's psychotic bears the burden of making manifest or making known this disruption in the social space. Now, once you think about that, what does that tell you? You need to treat the social spaces. You don't just treat one person, but you treat that person, and the family gets involved in the care. Friends get involved in the care. And it's a form of care that goes like this. They throw a lot of psychosocial care at the person right away, and it's basically, and so a lot of therapeutic care right away. They also work on building bridges back to the environment, into society, helping people regain employment, get back in school, that sort of thing. And everything occurs within a joint decision-making forum. So everybody meets together, the patient has a voice, and everybody comes to a group decision about use of medications, how long to be on medications, how often to meet, etc. And I think the therapeutic principle is that within storytelling, people telling their stories about past, present, and future, that can be a very healing process, and it can lead to a lot of understanding. And real quickly, there are some open dialogue training that is now happening in the United States and Western Massachusetts. There's some open dialogue replication projects that are on the drawing board. In other words, that we will try it here in the United States to see if we can replicate the good outcomes there. And it does involve a rethinking of the medications. Instead of one size fits all, it's basically for whom and for how long. And I think you can see in open dialogue really a new paradigm of care in which, rather than medications being the centerpiece, what you have is psychosocial care as the centerpiece, and then medications are an adjunct. And that's like flipping it, and that's the real paradigm shift that is out there to be embraced.
Well, a follow-up question to that is, how does open dialogue therapy relate to RAP?
Oh, that's a good
Are
question.
there comparisons?
Okay. Well, there are.
You might
Yes.
want to repeat that.
Right. What are how does open dialogue relate to RAP? That open dialogue is the kind of support system that I've been talking about since I first did my research back in 1989, that I discovered for myself that I needed a strong support system. And so an open dialogue really firms that up and makes it solid for people. And then it can become part of RAP. So I can see the two melding together in a way that we haven't yet done, but that can easily happen. That with RAP, you can use things like open dialogue, emotional CPR, and other things that people find they're useful. Mindfulness, meditation, there's all kinds of different things but it all folds into RAP as part of your wellness toolbox.
And I think also, Mary, you gave sort of 5 keys for recovery, right?
Yeah.
What were they?
Hope, personal responsibility, education, self-advocacy, and support.
Well, basically, you would see those in open dialogue.
You would see those in
nurturing hope, self-responsibility.
Yes.
You'd see
Education.
all those same principles
Yes.
that work with open dialogue.
So that, and I think we're at a time when all of us come together with all of the systems that we have evolved over time and make them available widely to people so that they have this. And I think our challenge as leaders, Bob Whitaker, we've got Dan Fisher here, we've got some other folks here in the room, that our challenge is figuring out how best we can get this information to you so that we can support your recovery. So we have another question here.
Yeah, we have one. This is about ECT therapy. What bearing does your research have on current mainstream beliefs about ECT? That is it effective for people resistant to medication, and does it do what it claims, rebalance neurotransmitters?
I would let Dan.
Go ahead, Dan.
I really was here as a guest. That's okay.
He just came to see what we were doing.
Is ECT effective? The answer is, in the long term or even short term, fairly short term, no, it is not effective. It basically, the best hypothesis for ECT treatment, and I wouldn't really call it a treatment, procedure, is that it causes a closed head injury. And there is a temporary euphoria from any closed head injury. But in most cases, if people choose ECT, and they should be fully informed, and I don't think it should be banned at this stage, I wonder about it in the future, they should understand there always will be short-term memory loss. It's just inevitable. Even Harold Sackheim, one of the great proponents of it, has agreed. And the FDA, there was a hearing last year, and I and other people testified as to the really quite severe side effects. And the FDA finally, their scientific advisory board, agreed that it should be classified as a category 3 procedure, not as category 2, which the ECT community wanted it downgraded to. So that's my story.
Okay, thanks, Dan. Thanks. We've got a question here. How do we provide places for people to be supported by consumers and professionals who are holistic to reduce or eliminate psychiatric medications? Individuals are scared. Their initial episodes were traumatic, and the risk of getting off medications is high. How do we find financing to provide non-medical model sanctuaries for people to be holistic and empowered? And the problem is that right now we don't have very many places like that, but we are seeing them come. We know about a place that's opening here in Vermont called Hilltop House. It's opening within the next few weeks, which is going to provide an alternative. And that's part of the healthcare and rehabilitation services. It's a house where I always wish that there was a pleasant place that I could just go, even now, just a place where somebody would give me food and treat me well and just let me rest and recuperate and revive myself and recover. And we need places like this. And that's what Hilltop House is going to be, a place where people can take a break from life for months if they need to. I hear of a few respite centers around. Dan, do you know of places like that?
Well, Pure Run Respite.
Can I just
Pure Run Respites, yeah.
And then, but what we really, this question goes to the heart of the problem.
Yeah.
What we do need is we need to make this information known.
Yes.
So we at least need to incorporate into possibilities that some people can do better off meds.
Yes.
because we know that some people want to come off meds, and then we need to provide places where that can be done safely.
Yes.
We need research to figure out how to do it best.
Yes.
One of the
Absolutely.
complete crazy things is we've been down this 55 years. There are no tapering protocols really that have been studied by mainstream medicine
Which
at
is
all.
incredible. Yeah.
And so you need safe places. And you also, if you listen to people who've done it, it's not just a matter of coming off the medications. You have to figure out what else you do to stay well. You have to replace it.
Yes. And
So you might need yoga, it might be diet, it might be exercise. It clearly needs some social support. So this question goes to the heart of the change we need in any sort of new paradigm, where right now we have a system that has gateways, entry, doors onto medication. Okay?
Right.
So we have all these ramps onto
but
medication.
but
There's no off-ramps.
There's no off ramps.
None.
No.
We need to build off-ramps where it can be done safely. We can study how to do it best.
Yeah.
We can study what happens to the brain as you come off. This is part of the real betrayal of patients. We put people on, but we have no way to help people off responsibly. And I hope that this information you heard here tonight can be sort of an evidence base for why we need to create some off-ramps.
Right, and I think you can start your own off-ramp by developing your wellness recovery action plan and then using it. Practice and practice with it. Keep using it, keep adding to it, keep revising it and changing it, and so that it will be there as a resource for you. I know somebody that used it just lately, getting off their medication, and then it got to be very difficult, and they needed to use that when things were breaking down section. They even needed to use their crisis plan, but they had it there. It was all written down. They could use it, and it carried them through. But I think you have to develop that early, and you have to practice it. You have to use it. Well, thank you all for being with us. Thank you, Bob, so much.
My pleasure.
For doing this.
Thank you for having me.
Thank you, Dan Fisher. It was just a fluke that Dan was coming through town, happened to stop by.
It was a pleasure. Thank you very much.
Yes, we're just really thrilled that Dan could be here. And and we have another webinar next Thursday afternoon at 2 on advanced directives. And Bob, do you want to?
Oh yeah. So I also run a website called madinamerica.com. There's a lot of people blogging on that site. Mary Ellen's blogging on it. Dan's blogging on it. We have here the editor, Kermit Cole, is here. One of the things that you'll see on this website is a couple things. You'll see people writing about these issues, thinking about these topics. You'll also see news reports that do tell of alternative forms of therapies. So it's just an information source, and that's madinamerica.com. And it's really now becoming devoted to rethinking psychiatry, or rethinking this paradigm of care.
Great. And be sure and read Anatomy of an Epidemic. Really important. So, thanks so much. Take care.